Okay, we're going to start part 2 of the neuro pediatric disorders. So if you'll get your PowerPoint ready, or not your PowerPoint, your outline ready for part 2, we'll go over that. Thank you. If you have any questions or concerns, as always, please don't hesitate to let me know. All right, part 2. Well, yeah, it's not wanting to open. Took a minute. All right, this is disorders involving developmental delays or defects, CP, cerebral palsy. I want you to remember that they're a child first and CP second, and it's easy to think that they're a CP child, and that's not the way that it is. It is not a single disorder. This is a group of non-progressive disorders of the upper motor neuron impairment that results in motor dysfunction. And what happens is these reflexes involve muscle movement, so that your primitive reflexes that govern cerebral cortex, like your tonic neck, your startle reflex, all of those reflexes continue to hang on. As far as cerebral palsy, it may be caused before, during, or shortly after birth, and it may be related actually to an unknown cause. It is the most common chronic disorder of children. Many children have some degree of mental challenge as well as physical disability, but not all. Some children have absolutely no problem being mentally challenged whatsoever. They just have the actual motor disability. So it just depends on what level and what type of CP that they have. It is most frequently caused by brain anoxia that leads to cell destruction. And we know when we have brain anoxia, we will have cell destruction. Intrauterine anoxia can occur due to faulty placental implantation, placenta previa, abruptio placenta, nutritional deficiencies, drugs, and infections. Some of these things y'all learned about or should learn about in OB. Now, during delivery, anoxia can be due to cord compression or the OP birth position. Premature infants are at an increased risk because they're immature central nervous systems. During the neonatal period, high levels of bilirubin in the blood can also lead to CP, and that's a rare form now. This occurs in approximately 1 in 1,000 live births. Clinical classification of CP, if you look in your book on page, let's see, not 1092, on page 1092, it goes over the clinical classification of cerebral palsy, or CP. You've got the spastic type, you've got the dyskinetic type, the ataxic, and the mixed type. And we'll be going over some of those. It is characterized by abnormal muscle tone and lack of coordination, and a variety of symptoms can occur according to their age. They're usually delayed in meeting all their developmental milestones that we learned about in normal growth and development, and they have accompanied problems like visual defects, hearing loss, speech problems, language delay, and can have some seizures, and again, some be mentally challenged. The three major types of CP that are listed there is the spastic type, which is on page 1092. This is the most common. It occurs, actually, this one says about 65%. Your book even says up to 80%. It can affect one or it can affect both sides. They will have hypertonicity. That means they're very rigid, very tense, tight muscles, and poor control of posture and balance. They have some muscle spasms. They have increased deep tendon reflexes with impairment of fine and gross motor skills. With the dyskinetic, this is 20%, affects about 20%, and can affect all extremities. It's very purposeful, uncontrollable, involuntary movements. They do have some muscle tension with a lot of drooling and dysarthria, or poor speech articulation. With ataxic, which only accounts for about 5%, they have poor balance, poor coordination, and a wide-based staggering gait. Very repetitive movements are performed. Motor impairment may be minimal. Sometimes it's most apparent during the physical activity, such as running, or if they're severely disabled, you can tell that as well. Visual, hearing, and speech deficits may or may not be present, just depends, and we've already talked about, depending on the amount of brain damage, we may have some mental challenging. It's about 10% that have the mixed type. Clinical manifestations are listed on page 1092, also in your book. It goes over delayed gross motor development, abnormal motor performance, particularly feeding difficulties, and we'll talk about that later, alterations of muscle tone, abnormal posturing, reflex abnormalities, and associated disabilities. And it says those are things like learning disabilities, seizures, behavioral problems, and sensory impairments. Now, the warning signs of CP, the big thing is delay or failure to control head movement and to roll over. So delay, if you've got a kid that has that floppy head that doesn't gain that head control and has strong head lag, then that's a big one. If they're not rolling over when they should, that's a big one. There's also other signs of CP on page 1093 in box 32-3. Failure to meet any developmental milestones, persistent reflexes, poor head control, head lag that lasts past 3 months, rigid, stiff arms, scissoring of the legs, pushing away, arching their back, stiff posture, floppy or limp body posture, inability to sit up without support by 8 months, using only one side when crawling, feeding difficulties, persistent gagging or choking. After 6 months, the tongue continued to push food out of the mouth, extreme irritability, failure to smile by 3 months, and lack of interest. So everything we talked about in growth and development, them meeting all these developmental milestones, you will see the child with CP not meeting those developmental milestones. There is no cure. Braces, splints, and special appliances to help perform their activities, and it shows some of those on page 1093 in your book. Range of motion exercises to prevent contractures. They may have to have some orthopedic surgeries to correct contractures where they go in and do muscle releases and tendon transfers, and they do those a lot. Anticonvulsants to control their seizures, and physical therapy. They may have what's called baclofen, which is an antispasmodic drug administered intrathecally through the spinal cord that helps with those spasmodic seizure-like activity and helps control that movement some. Preventing injury is important. They may have on certain protective gear like helmets and knee pads. They need appropriate environment, safe environment, and toys. They may have electronic devices like wheelchairs with microcomputers on them and voice censored. They may have elective surgery that divides certain sensory nerve roots that causes the spasmodic movements. So they're coming out with more and more stuff. There's no cure, but there is supportive devices. Each child should be treated individually. Nursing care should focus on adequate nutrition, maintaining skin integrity, promoting physical mobility, promoting growth and development, and emotional support is very, very important. When we're saying promoting nutrition, adequate nutrition, that would be like high-calorie diets because of the increased muscle tone. They may have difficulty chewing, so they may need certain help chewing, like the jaw support method to help with swallowing, and it shows that on page 1097. You can see there the manual jaw control that is provided anteriorly and the manual jaw control that's provided from the side where you actually help them move their mouth back and forth. They may have padded spoons, large spoons. They may have G buttons where they're getting fed through G tubes as well. Skin integrity, I talked about that. We want to maintain, especially support when they're on off their bony prominences. Physical therapy will help with range of motion and to help prevent contractures. Again, promoting growth and development. You need to remember these children have CP, but a lot of them are not intellectually disabled at all. So use appropriate terminology and treat them like you would anyone else. They need a positive self-image. They need to be praised and complimented. You need to set realistic and attainable goals and encourage their involvement as well. As far as a clinical tip, just a little clinical tip for you. All infants who show symptoms of developmental delay, feeding difficulty caused by poor sucking or abnormalities of your muscle tone should be evaluated by using 2 simple screening tests, and this is for CP. One of them is to place a clean diaper on the infant's face. The normal child will usually use both hands to remove it, but the child with CP will use one or not try to do it at all. Turn the infant's head to one side, and if they have a persistent tonic neck reflex beyond 6 months, that's also an indicator of pathological condition like CP. So those are just a couple things that you can do. But if you're seeing all of these reflex developmental milestones not being met, that is definitely red flags for CP. All right, Down syndrome. Down syndrome, now called trisomy 21 syndrome. And I believe this is in another chapter. Let's see, maybe 576. Yeah, it's on page 576 in your book. This occurs in about 1 in 1,000 live births. Etiology is unknown. Likely it's multiple causality of different factors. About 95% of all your cases is attributed to an extra chromosome 21, which is why it's called trisomy 21, because you have 3 instead of 2. Statistically, there's a greater risk in children of over women, particularly those over 35. However, the majority of children with Downs are born to women under 35. More of your older women have maternal testing. They get better prenatal care. They're offered amnios more often, so sometimes they will find out earlier that they are having the children. Diagnostic-wise, it's based upon clinical manifestations and chromosome analysis, a lot of septal defects and respiratory tract infections. As far as clinical manifestations, there's a large box, sorry about that, on page 577 in your book. But the child that's in the picture shows you the most common on page 576. It says Down syndrome in an infant. Note the infant's small square head with the upward slant to the eyes, the flat nasal bridge, the protruding tongue, the mottled skin, and hypotonicity. So those are your most common signs and symptoms that you would look for. Usually they will do what's called the triple test. They will do an alpha-fetal protein. Usually it will be decreased with Downs. You'll have a high HCG level, and they'll also do an amnio. So they will look for different types, and again, a lot of it is based upon clinical manifestations too. Prognosis, life expectancy has improved. It does remain lower than average. Over 80% live to around age 30 and beyond. It's associated with premature aging, and it's strongly associated with the development of Alzheimer's disease. Nursing considerations, they are going to need lots of family support. Support groups, there's lots of options out there, and there is some placement options. They want to assist family, though, in providing and preventing any kind of physical problems that can occur. If it's in the infants, hypotonicity is a problem because of the decreased muscle tone. So it can lead to positioning and attachment problems because they're very limp and flaccid. So you want to encourage swaddling tightly in blankets. Respiratory problems are common because of the decreased muscle tone and the underdeveloped nasal bone. So you want to make sure you're cleaning the nose with a bulb syringe and rinsing their mouth after feedings. Other things like cool mist vaporizers help, changing positions, postural drainage, percussion, good hand washing, and antibiotic teaching to take it all if they have a problem with that. Feeding requires a special care due to the increased risk of aspiration and difficulty feedings. You want to make sure that you're watching them very carefully, giving them small, frequent foods. They may sometimes have to have a small, straight, handled spoon because they have that protruding of the tongue a lot. Increase fiber and fluid in their diets, dietary management to prevent obesity because that is common. And then skin care. Minimal use of soaps that are harsh, application of lubricants and lip balm because they do have issues with breakdown. Average IQ is around 54 for moderate downs. They do get concrete concepts a lot better than they do abstract concepts. They have trouble with abstraction. That's why you'll see a lot of times they go to a lot of people and love a lot of people because they don't understand that concept as well as they do like hot and cold. So they have a better grasp of their concrete. Now during infancy, again, it is soft and their skin has some issues, but as they get older, the drying and the roughness and the cracking becomes a problem. Life expectancy today, if you were to look it up, would be around 55 plus. Genetic counseling for older women, amniocentesis. They can do chromosomal analysis of fetal cells that can determine the presence of trisomy 21 as well. Alrighty. Again, they want to be treated as a person. Alright, this next part you'll have to take out and look at because the way it's in there, it's from the sideways. So you'll have to print this page as we're going over it. This is the different differential features of the common muscular dystrophies that you'll need to know for the test. There is a picture in your book. Let's see, I think this is on 1162. Like I said, there's not a chapter in your book on neuro. It's kind of spread all out. So it's not that I'm jumping all around. Your book kind of jumps around too. And it's not the right page. Let's see. Muscular dystrophy. I bet it's in here. Okay. It's on page 1106. Okay, 1106 in your book. There are several types of muscular dystrophies, as you can see here. Characteristics, Duchenne's is one of the most popular kinds, also known as DMD. One of the things that you'll see there at the top of page 1107, it shows you the initial muscle groups that are involved in muscular dystrophies, depending upon what type that they have, and it affects certain muscle groups. If you look on page 1108, it shows you a child with Duchenne's muscular dystrophy attaining standing posture by kneeling, then gradually pushing their torso upright, and then walking up their hands with their legs. This is called Gower sign, and that is, they have marked low doses, and that is a telltale sign. If you can get them on the ground and see how they stand up, they'll almost always use Gower sign if they have Duchenne's to get back up. So they almost start out like a duck-like position and then get up. With Duchenne's, this is called pseudo-hypertrophic. It is also severe X-linked, so it affects males. You can see there in the picture A, the main groups of muscles that's going to be affected on page 1107. There's an enlargement of these muscles as a result of their infiltration with fatty tissue. This is most common in your 3 to 7 years old, but it can occur anywhere from 18 months to 4 years old at the onset, but usually around age 3 you'll see it. You have progressive muscular weakness, wasting, and contractures, and this is on page 1107 in your box. Calf muscle hypertrophy, loss of independent ambulation by age 9 to 12. And remember, these children are born perfectly healthy, and then about age 3 they start having these issues. Generalized weakness during their teenage years. Again, they have pelvic and shoulder and girdle weakness. They have waddling gait, cardiac involvement, and they may have some mental challenges in about a third of the cases, being less than 70% IQ. In early childhood, muscle weaknesses start usually in the lower extremity. The child will start tripping over themselves a lot, toe walking up on their calves. So that's some telltale signs that they may start having some trouble. Progression, it progresses very quite severely, leading to inability to walk. Again, your book says between 9 and 12. This says between 7 and 11. So by age 12, usually they can no longer walk because it affects the muscles of the diaphragm. Death from cardiac and respiratory failure in their second and third decade of life is common, and they are looking for gene therapy to try to help with this. Becker's, and also known as BMD, is a benign X-linked that affects males. This involves muscle membrane stabilizer that was affected and is replaced with connective tissue and fat. So anytime you replace something with fat, it's not going to do what it's supposed to be doing. Onset, it tells you here, is anywhere between 5 and 25 years. Mainly your teen years is when it affects you. It's a milder form DMD. Wasting of the pelvic and the shoulder muscles with normal cardiac and mental function. So it's very similar, but again, milder than the DMD, which there are no cures for any of these. Gradual progression, inability to walk by 25, and usually a normal lifespan. You just lose your muscle ability. The limb girdle type can affect either sex. It affects mainly on the onset of your second and third decade of life, with adolescence and early adulthood being where the main onset occurs. Upper extremity and neck muscles with the lower extremity and hip weakness. So just like it says, the limb girdle area. The pelvic and shoulder girdle area can also be affected. Progression is extremely variable. You will have severe disability within 10 to 20 years after the onset, and a lifespan that's shortened by about 10 to 20 years. The facioscapulohumeral can affect either sex. It's an autosomal dominant. Usually it affects the second decade of life, early adolescence. With this one, facial and shoulder girdle muscle is involved. They get to where they can't raise their arms over their heads is one of the red flags with this type. And they have a forward slope of their shoulders. They get to where they can't close their eyes completely during sleep as it progresses, and it leads to the inability to walk. It has a slow progression, and usually they can have a normal lifespan. With the myotonic, can affect either sex. This is an autosomal dominant. Can occur anywhere from birth to fourth decade. Muscle atrophy with multiple organ involvement. The heart, the lungs, the smooth muscle, and the endocrine system are all affected. It's usually gradual if the onset is in adulthood. All of these tests, no matter which type of muscular dystrophy, they use what's called the EMG test, which is and do a muscle biopsy as well to figure out what type of muscular dystrophy is affected here and which muscles and which limbs. Treatment for these types of, again, there is no cure for muscular dystrophy, so it's supportive, physical therapy, orthopedic procedures to decrease deformities, and assistive devices to assist them with their ADLs as needed. So it's really pretty much supportive when it comes to muscular dystrophies. All right, that's it on that. Part 2 is done. If you have any questions or concerns, let me know. Thank you.